Good evening, everybody. Thank you for being here. Thank you for those of you who are watching through a live stream. This is an organization called Protecting Reproductive Health. We are a grassroots organization that wants to educate people on the effects of the anti-abortion laws in Tennessee and the effects that they are actually having on women, girls, and their families at this point in time. So we have gathered together a group of panelists, and I'm going to introduce Dewana Wade, who is our moderator for tonight. Dewana is the CEO of Salama Urban Ministries, Inc., is committed to continuing the stellar services Salama has provided for more than 38 years. Dewana has previously served in multiple leadership positions within the YMCA of Middle Tennessee and the YMCA of Greater Kansas City. Dewana is well-versed in the areas of youth and community development, strategic planning, and executive coaching, and has served as a consultant and mentor to organizations, churches, and individuals in these areas. Her board and service within the community have primarily been in the areas of education, justice, and equity. Her most important role, however, has been as parent to 2 adult children and guardian to her niece. Please welcome Dewana Wade.
Good evening, and thank you very much, Sandy, for the introduction. And I'm very, very glad to be here. I think this is a wonderful opportunity for us to just have some conversation and learn some things from our experts. We are here tonight to recognize the topic of women's reproductive health, that it can be considered a very sensitive topic, but the purpose of our panel discussion tonight is not to evaluate the broad question of pro-life or pro-choice. It is simply an educational forum providing factual information on a variety of medical issues and outcomes impacting treatment for women resulting from the current Tennessee law. I do want to share at the outset that we are joined tonight by the awesome Captain McCoy from the Sheriff's Department, who will help us to maintain order if that becomes necessary. Again, educational conversation. We don't expect that to become necessary. However, there won't be an opportunity for outbursts. There won't be an opportunity for people to approach the panel. And if we believe that there are any concerns around safety for the panelists or anyone in the room, we will ask Captain McCoy to step in and to take care of that for us. And we thank you for that tonight. And so I would like to go ahead and get it started because we have just a little bit of time and a lot of conversation to have. And I'm really excited about that because it is important information to be shared. And so I want to talk with you and share with you who has joined us this evening. And I will start on the far end and introduce you to Tyler Chance Yarbo, who is an attorney in private practice at Dodson, Parker, Bim, and Caparella, PC, where she handles a broad range of litigation matters and serves as the managing partner. She began her career as a lawyer working as public defender in Nashville. Tyler is also an adjunct professor at Vanderbilt Law School teaching trial advocacy and is the current board chair for Tennessee Freedom Circle, advocating to change Tennessee's abortion laws. She's married to Jeff Yarbrough, and they have 2 children. Welcome.
Thank you.
We also have Dr. Ann Bartek. I'm going to skip over you, Dr. Oliver. We have Dr. Ann Bartek, who received her medical degree from the University of Michigan and did her residency in psychiatry at Vanderbilt University Medical Center. She's practiced for over 30 years, and she and her husband have been married for 46 years and have 2 grown children, both of whom are psychiatrists. They have lived in Gallatin for 37 years. And we also have with us Dr. Nicole Oliver. Welcome, Dr. Oliver. Dr. Oliver is an obstetrics and gynecology specialist in Hendersonville and is affiliated with TriStar Hendersonville Medical Center. She received her medical degree from Indiana University School of Medicine and started her private practice in 2009 in California. She is a fellow with the American Board of Obstetrics and Gynecology and is married with 2 children, ages 12 and 10. And finally, we have Dr. Dwayne Harrison. Dr. Dwayne E. Harrison is an emergency medicine physician in Hendersonville, Tennessee, and is affiliated with TriStar Hendersonville Medical Center. He received his medical degree from Meharry Medical College School of Medicine and has been in practice for more than 20 years. He and his wife live in Gallatin. Welcome, panelists. Thank you all for being with us tonight. And so again, because we have shared that we are, I would say, short on time for a really, really good conversation, I want to go ahead and get us started in the conversation. And we are also asking and inviting you in the audience, if you have questions. We have the good old-fashioned way. You need me on the mic. Really, I talk so loud. We have the good old-fashioned way of you all being able to get other information if your question is not asked. And so there are note cards in the audience, as well as ink pens, that if you have a question, please complete a note card, give it to the lovely lady, and she will make sure that that gets to us or to me, and then we will ask that question of the panelists. Any questions? All right, well, let's get rolling. Can you explain what the anti-abortion laws mean to pregnant people and doctors? And Tyler Yarbrough, I think I'm going to start with you for the response to that question.
Sure. I'm happy to take the lead, but as I sit next to professionals who are, as I like to say, really where the rubber meets the road, I'm eager to hear from them as well, in particular about how this affects the patients that they treat. But just from the perspective of the law, right now, Tennessee bans abortion in almost all circumstances. It's not a crime. I'm being told I'm going to hold it. It's currently a Class C felony to terminate a pregnancy unless there's a specific exception that is acknowledged in the course of providing care. And that exception exists when, in the physician's reasonable medical judgment, the termination of the pregnancy is necessary to prevent the death of the pregnant patient, or when it's necessary, and I'm going to give the legal jargon because it's crazy, to prevent a serious risk of substantial and irreversible impairment of a major bodily function of the pregnant woman. Notably, the exception does not apply if there's any emergency in connection with the pregnant patient's mental health. So there's a lot to unpack there, which is why lawyers and physicians are trying to understand what this actually means in practice, and why I think physicians are finding it so difficult to provide care in what they would ordinarily describe as an emergency circumstance. But when you have all that legal language, that's not really medical language, as you all learned it in medical school, but when you have all that legal language, it really stands as a barrier to care.
Thank you. Would one of our doctors also like to answer that question?
So I think I'm the OBGYN here on the panel again. So I think the exposure that I have, is typically kind of through the emergency room setting where Dr. Harrison works, but, he sees the patient initially and then consults me for, treatment and management and so forth. Those are the kind of situations where the types of situations that Tyler described are kind of already in place. Maybe there is a miscarriage happening and the patient could be bleeding excessively to the point that she might require a surgical intervention. And where the kind of abortion component actually comes into play is if there's actually a fetal heartbeat present. So a lot of it is nuance that actually becomes pretty infrequent, believe it or not. If I have a patient who's actively having a miscarriage that might require surgical intervention, the ultrasound probably does not show a heartbeat. It shows that there is a fetus in the uterus, but it's not an alive fetus anymore. So the specific legal concerns are oftentimes, believe it or not actually present. But the more specific situation where it would be if the mother is bleeding heavily, needs medical intervention, and there is actively a heartbeat. Or kind of a slight extension to that would be if there's an ectopic pregnancy where there can actually be a viable heartbeat. It's not a viable pregnancy. The life of the mother would be in jeopardy if it were left unmanaged, either with medication or surgery or whatever would be appropriate. So fortunately, to kind of answer the question, what is the impact on how I can manage the patient given the legal situation here, specifically in the state of Tennessee? Fortunately, it has not significantly impacted my ability to manage a patient. A lot of times, in particular, because it's the emergency room setting. In my private practice, believe it or not, I don't oftentimes have patients coming to me saying, I have this undesired pregnancy. I'm, based on what we've determined, I'm, say, 10 weeks pregnant. can you help me achieve, a medical termination? I don't have a lot of those patients. That's just my specific practice. And if I did have that situation, what's the impact for me on how I can manage that patient? Whether or not I'm the right provider to actually perform the termination, or if that's even something that I am trained to do, that's not the question. It's how can I provide the care that patient is seeking? In certain states, it would be a referral to the facilities that can do those procedures based on the patient's, particular status, gestational age, et cetera. Here in Tennessee, it's not a referral that I can do locally. It's really more, I know you can go to this state and have it done, so buy your plane ticket, and that's the best we can do, type of thing.
Thank you for that information. Certainly, Dr. Bartek.
I'm going to look at it in not so much specific patient care, but in a broader sense of how this will affect our state over time. I think our abortion laws cast a rather chilling atmosphere over the issue of recruiting OBGYNs to our state. We already have areas of the state that are essentially OBGYN deserts. And there are women who have to drive an hour or two or more in order to get obstetric care. We're just making it much harder to bring more people in the specialty to our state.
Thank you for that. Thanks, Dr. Harrison.
And we're making them more desperate,
Them being,
the patient. And that's the concern for us in the emergency room. When you open the American College of Emergency Physician journals on this subject, the first admonition is to get involved. And for physicians who are on the front line, we sometimes forget we actually do have the ability to make changes, recommend, help set policies. And so for us, it's getting involved. For my area, I lean heavily on OB every time a pregnant woman comes in with any complications. But what we find is that we have been fortunate, at least in our area in Middle Tennessee and Sumner County, we've been fortunate. We haven't had some of the things. I've done this now. I'm 66. I started when I was 26. And I have seen the days of coat hangers and pills and meds and things that somebody's grandmother told them to take, ingest, insert. And so when I hear about the things that we are proposing as a state, it takes me back to some dark days. And we have in the emergency room had patients who have come in and behind a closed door confessed that they are trying to abort this fetus. And they are concerned about things that are changed now and happening. And we have to dive in. Somebody wrote a question that said, are you responsible for reporting a patient who comes in and admits that they tried? I don't know the answer. I've not reported, and I know my colleagues, because I'm the director, have not reported, but it's a valid question. We don't know the answers. What we do know is that EMTALA laws that guarantee the right to medical care were started in this very arena. This is why we have EMTALA, pregnant women getting care. Anything right now that jeopardizes that, we are urged, encouraged to fight. So far, reporting is on the side of my patient can't get care, and I'm holding you responsible for it. We haven't seen a pendulum swing that says, you treated this patient for this, and now someone is reporting you.
so it sounds like your practices have been able to continue to do the level of care that you have done to this point, pending further reporting and things of that nature and requirements from the state.
But it's like the sword of Damocles. It's just
For the next shoe to drop. Gotcha.
I think just to add to that too, I mean, I have had patients who present to me for whatever, not anything related to it, but part of their history is that they had a recent pregnancy termination, and oh, I had to go to Illinois or I think Georgia, surrounding states. So they tell me that these are the things that they had to do, but I think because they live in Tennessee, they know what the laws are, they know what the resources are, they've taken those measures. So it's not that they haven't done it, but they did have to go to that extent to do it.
Get it done. And panelists, this is great information that you are sharing. And we have lots of questions. And so I'm going to ask you, if you can, make sure that your answers are as concise as possible, that then also does answer the question. And if not, we may end up saying just a handful of minutes later. And we ask also that potentially there will be an opportunity for you to send your questions in and get those. Oh, there's one on my desk. Thank you. I didn't even see you come up here. And would you please speak directly into the mic, like I'm doing, that I'm so unused to. Thank you very much. And so you all have also answered our next question, and so I'm going to go to the next one. The Tennessee trigger law and how it impacts Tennesseans is complicated. There's a lot of legal language that everyone is trying to interpret, and is often met with confusion and contradictory results. How has this impacted your work and the citizens you serve? Which you've also kind of answered as well, but if you'd like to add some information specifically around the trigger law and how that has impacted you all, that would be helpful.
Yeah, I think the physicians have pretty well addressed that, but I would say, I would point your attention to, there's an article in ProPublica about a physician at Vanderbilt and her attempts to help patients, a particular patient, and sort of the sort of hurdles that she went through in talking to legal counsel and sort of the administrative side of the hospital in her attempts to provide what she thought was standard of care, abortion care. And it's a very compelling read, and so I commend that to you. That really focuses on, the sword of Damocles that fell on this particular physician and found a desperate patient needing help.
Wonderful. And if you would, Ms. Yarbrough, share that with our PRH team, so that can get on the website or something of that nature, because I missed altogether the name of the article. So thank you for sharing that. I'm going to go ahead and go with a couple of questions that harken back to some of the conversation we've just had. Has there been any instruction to medical professionals on reporting? Any direct instruction around that you all have seen or heard or felt? Because I know you haven't had to report yet or have not reported yet, but you've not received any specific instruction around
I
that
have
either?
not received any specific instruction. If I had a situation where I felt like I need specific instruction in order to not be charged with a Class C felony or something to that effect, we do have a hospital ethics committee they're basically a 24/7 kind of team of I'm not even sure what their title is, but people with the ethics background that I would call upon, and I have not yet had to do that, but I know that resource would be available to me if I needed it. But otherwise, in terms of specific instruction from the state medical board or anything to that effect, I have not been told, here you have to, do this training or follow these protocols or something like that. So,
Thank you. Ms. Yarbrough, are there any laws against traveling to another state for an abortion? Any local laws for that?
No.
No.
There's one that's travel adjacent that will be heard by Senate Judiciary on Wednesday. So one point of clarification, the trigger ban specifically says that women who obtain abortions cannot be charged with a crime, okay? Just the physicians that perform them. Sorry, guys. And so it is not a crime to travel out of state to obtain an abortion. It is not a crime to assist somebody to travel out of state to obtain an abortion. There are efforts underway currently in our legislature to make it a crime in particular pending before the legislature right now, to make it a crime to provide, to recruit, transport, or harbor a minor who, for the purposes of obtaining an abortion without their parents' or guardians' consent.
Thank you. Dr. Harrison, this one is specifically for you and then any other panelists that would like to speak. How have the anti-abortion laws changed your approach to pregnant people in the emergency room?
They haven't.
Awesome.
Concise.
Pretty straightforward. Not bad at all. They have not. Thank you. We all need to make sure that we go to Dr. Harrison's hospital. All righty. What is hospital? I knew there was more.
So no, I'm just gonna read. Okay, I harp on EMTALA because in the United States, that truly is the basis. It's the bedrock for anybody to be able to walk into any facility, ride into any facility, and receive treatment. I can drive to Johns Hopkins, get in the parking lot, have my kidney stone, and walk in and be seen. I can drive to Rochester, Minnesota, the original Mayo Clinic, and I can have my CT angiogram of my heart and get some of the best doctors in the world. We have them here in Tennessee, but I can get my stuff done there. So for us, in the emergency room, EMTALA rules. And all I need is a medical condition that puts my patient in jeopardy. The law is broad when it comes to that medical condition, but it's broad because we wrote those laws. They had help in writing those laws. So if you come into my emergency room and I deem that a medical condition exists that will put your life in jeopardy if I don't do something, they can't come at me and say, we practice medicine better than you. You were wrong. They will try, but that's going to be hard to do. The fortunate thing for us is I've lived long enough to see situations in which I have trauma and I have to make decisions on the life of the patient and the life of an unborn fetus. I'm not looking for that day to come. I have in my own mind an idea of what that will look like. But again, I'm old, I've done this a lot, I forgot half the stuff I've done in emergency medicine, and we did it before we had the number of subspecialists that we have. But we have made decisions about life and death when a mother's life is impaired and a fetus is younger than 20 weeks. And for us in our emergency room, younger than 20 weeks stays in the ER. Over 20 weeks goes to my colleague. So for us, we get a lot of what's going on. But no, it hasn't changed.
I'm glad to hear that. These next questions will talk about miscarriages and what needs to happen or can happen. And so I'm going to move forward. What is hospital policy for patients experiencing a miscarriage? And has your treatment of miscarriages changed since the enforcement of Tennessee's anti-abortion laws?
I'll give a concise answer like Dr. Harrison did at first. No, it hasn't. But the treatment is there's a lot of clinical nuance to that. So if she 8 weeks and she came in with some spotting and she has a viable pregnancy and she wants that pregnancy, that she has no interest in a medical termination or any sort of termination. So the management of that is straightforward and has not changed. And the emergency room situation is not the same as the patient who's seeking a medical or a elective termination of a pregnancy. So I'll just keep it at that the emergency room treatment is very different because it's not the same situation. A patient who has an 8-week pregnancy that maybe she's losing that pregnancy, she might very well want that pregnancy. That's a medical condition that's very separate from the other patient or lady who has an 8-week pregnancy and actually does not want that pregnancy, desires an elective termination, but she's otherwise very stable.
And so hospital policy also then has not changed to date. Awesome. So several women have reported delays of days or weeks to get DNCs for missed miscarriages, or they're encouraged to miscarry at home to avoid DNCs. Do you foresee this trend continuing, or do you think this missed miscarriage care will be clarified or improved over time? And that is a question from the audience.
So for me as the obstetrician, when a patient has a missed miscarriage, which is basically, we call it missed because it's asymptomatic. It's not an elective, termination of pregnancy. It's sort of Mother Nature, if you will. The pregnancy just didn't continue, and there's no longer a viable fetus in the uterus. So part of that discussion, it's actually a pretty lengthy discussion because there are a lot of options for treatment. One of which is, and this is kind of how I present it to the patient, one of which is just watching and waiting. We have a little bit of a timeline on that because we don't want infection to set in and that type of a thing, but watching and waiting with precautions for what to expect if that spontaneous miscarriage starts, that's kind of option number one. Option number two is to, induce a miscarriage with medication. Now, that's not an elective termination of pregnancy. We're talking about a non-viable pregnancy. There's no heartbeat. It's unquestionably not an elective termination of a pregnancy. And then the third option is to go straight to the DNC. So in terms of waiting versus having it done immediately, it's really all about the urgency of the situation. So if the patient is in the emergency room, literally hemorrhaging, and that is definitely something that can happen. It's 2 o'clock in the morning, that patient's gonna have her DNC within probably an hour, maybe 2 at most, because it's medically necessary for the patient to have that. If the decision was made electively, there's no heavy bleeding happening and the patient is stable, then it's done on more of a scheduled basis. So I'm not sure about waiting an extensive amount of time, if that's that's a discussion that the patient has with the physician in terms of timing. A lot of patients say, you know what, I'm going out of town this weekend and I don't want to have the procedure before I leave, or maybe I do want to have it before I leave. Can we get it in? So some of the timing is a little bit more personal, I would say.
Thank you. If a person who is undergoing treatment for a severe condition such as cancer gets pregnant, can they receive abortion health care in Tennessee? And we believe this might be a good question for Attorney Yarbrough, according to the law.
I'm really curious to hear what the doctors say. I mean, I think it might be cancer dependent, is my guess, because a physician can provide an abortion when basically it's necessary to save a bodily function, right? And cancer may involve, a severe and irreversible impairment to a major bodily function or death. That's right. So I think that is probably a question within that is going to be case by case, cancer dependent, patient dependent. All sorts of sort of factors will be at play in determining whether an abortion is something that patient could legally obtain here in Tennessee.
Dr. Harrison?
The concern for us in the emergency room that patients will bring up is, I've read the side effects of the drug they're asking me to take. None of them sound favorable to a pregnancy. What am I about to do to an unborn child with this medication? The guilt that comes with that is tremendous in itself. Then going through that and being told you're going to have this baby come hell or high water unless some act of God occurs, we haven't even been in this long enough, and we've already had those kinds of questions because we've had to walk in the room and tell patients we found cancer and you're pregnant. And the questions become, well, first of all, what's the treatment? To the point where we've had patients say, then I won't get treated because of the baby.
It's a question with a lot of nuance because a lot of it has to do with the type of cancer, the gestational age of the patient, whether the patient wants the pregnancy or is it to begin with an undesired pregnancy. I think that question, desired versus undesired, is kind of a foundation for almost every question that we might have here, because a lot of the questions, they seem to potentially have a controversial, answer, but a lot of it has to do with what does the patient actually want. So I think the assumption is that, all of the patients that might, have these questions applied to them are all patients who also have undesired pregnancies, and that's just not the case. 99+% of them likely have a desired pregnancy. It's also not a question or a situation that I, as the obstetrician and just the patient, answer ourselves. We involve the oncology team. We involve high-risk obstetricians. So I did have a patient not too long ago who had a history of lymphoma and had concern for a recurrence, and she's currently pregnant. It was a very desired pregnancy. She had another child at home. So I need to treat myself so that I can be around for my child at home, but I also have this very desired pregnancy. So how can I best manage, the treatment that I might need and even the workup that I might need for, even determining if I have a recurrence. So it was a team effort, which, really at the center of it involved what the patient, truly wanted for herself and her family. So I think to get to the root of the question of, probably the most pertinent situation would be, you have an 8-week pregnancy and let's say a new diagnosis confirmed with pathology of a cancer that requires an aggressive treatment, and we are extremely remote from delivery, and we have an extremely aggressive cancer that needs to have treatment right away. So the question of, can that patient receive abortion care in the state of Tennessee? I would, like I said before, involve very, very strongly my ethics committee to see what, and it would probably even involve something beyond even the scope of my own hospital, to see what kind of, options she would have within the state of Tennessee. As her provider, I would say, and again, this gets down to sometimes the means of the patient and what the patient truly wants. If you really wanted to have an elective termination of your pregnancy, I would provide no judgment to the patient on that. That's perfectly her option. These are kind of the options that you might have quickly so that you can move on and get your treatment quickly versus probably the bigger fight of trying to have it done in the state and seeking out the options that we might have with, ethical, recommendations. And then, too, the other component of this, which kind of has to be applied to all of the questions, too, these have to be done by the right provider. I'm just going to say, I personally am not trained in abortion care. It's not something that I provide, and a lot of these patients are people in the second trimester. A second trimester termination of any sort, elective or otherwise, is a completely different animal from a first trimester, management. And you have to have it done by the right person. Coat hangers and things like that completely aside, it has to be done even surgically and medically done by the right person in the right facility who can handle just the logistics of it. So another additional nuance to all of that is how far along is the patient. So the discussion of maybe saying to the patient, to get this done more quickly, maybe even more safely, I might recommend that you, travel out of state. So again, how does that affect, how does the Tennessee laws affect my ability to manage the patient? There's a true area where it might affect my ability to manage my patient in terms of the options that I can provide.
And similar to that question, because we're talking in the last question about cancer and sometimes a greater, more speedy need for those kinds of decisions. And so many drugs used to treat mental health come with damaging side effects to embryos and fetuses. If you have a patient with one or more mental health conditions such as PTSD, bipolar disorder, depression, anxiety, etc., is your treatment of them as a physician different or a little more lengthy, or you have more time than you would in the situation of cancer that potentially requires a much more quick response?
There's no question that some of our drugs that we use to treat mental health conditions are teratogenic. They can cause birth defects in babies. And although we're not unique in that regard, chemotherapy and a variety of other medications we use to treat various conditions can also be teratogenic. With patients with severe mental illness, particularly bipolar or schizophrenia, taking them off their medication presents a clear risk to them, whether it's for suicide, psychosis. It's very high risk to take these people off their medication. Now, that being said, there are some psychiatric medications that are safer than others. I mean, we never say anything's completely safe, but certainly I might take a patient off of a mood stabilizer, which is likely to cause spina bifida, and try them on an atypical antipsychotic, which tends to be much better tolerated. So there are some options, but it needs to be managed, and we need to be very aware. I think the other question embedded in that, I think, is what other issues arise when we're treating someone with one of these disorders. I do want to emphasize, I'm very protective of my patient, that just because someone has a mental illness does not mean that they're incapable of being an excellent parent. And I really want to emphasize that. Sometimes, however, patients are not in a position where they can manage rearing a child, and that puts them in a position of making a tough, well, they have to make a tough call. I generally do not tell my patients what to do. I would give them the necessary information. I would explore what this would be like for them and what their options might be. I would also look at their support system. If someone is living in some kind of halfway house situation because they have a chronic psychotic disorder, they're probably not going to be able to raise a child. And these are all things that warrant discussion. I want to deviate to an area of mental health that this question doesn't specifically bring up, but I think is very important, which is the issue of addiction. Because Dr. Oliver can tell you certainly that she has probably delivered babies who are born addicted. One of the particularly complicated one is opiate addiction, which is really quite the problem in our state right now. Generally speaking, we do not withdraw patients from opiates when they're pregnant. It usually is not that successful anyway. Patients are often, they just relapse. The problem is then that a baby can be born with addicted to opiate, and they go into withdrawal as soon as they're born. It's very tough for the baby. And what's interesting is Tennessee, and you may be able to speak to law, so that if a baby is born with something like this, the parent, the mother, is potentially liable for causing her baby this harm and could theoretically be prosecuted for that. So that puts a patient like this, between a rock and a hard place. They're strongly addicted, they have trouble getting off the drug, but if they stay on the drug, then the fetus is going to be born addicted and it's going to withdraw, and then they're legally liable. Like I said, between a rock and a hard place.
So everybody that she has mentioned, I see. Okay, and I will tell you, the one thing that you're neglecting is these. When I say neglecting, collectively in our minds, we neglect the fact that many of these people come to the emergency room because they fear what's going to happen to their baby while they're on these medications. So they don't even say, I'm going to get off my meds. They just try and get off on their own. And then they show up in the emergency room. They do that with their mental health meds. They do that with their medications that are designed for other treatments, because they sit. My mother-in-law will sit in the parking lot of the drugstore after picking up 3 meds, read everything about it, only to call me and say, I'm not taking any of these. I've read the side effects of all of them, and I don't want this. You need the meds. Poison is poison, but sometimes it's good poison. Come on, let's come home, take the meds. Well, patients make those decisions, and they make those decisions, and then you reap the benefits. An opioid addicted female who realizes she's pregnant, has had 5 pregnancy tests. I guess she's trying to figure out she's not pregnant, and then comes to the ER to be verified that she is pregnant. And you notice that she's jonesing, and you ask, is something else going on? And then they will confess behind closed doors, because for me, I'm in a no judgment zone. Is there something that I can treat that's causing your heart rate to be 134 and you to be anxious and sitting on the side of the bed? All you need to do is tell me so I can help. I'm not here to judge you. And they will say, well, since I took my first pregnancy test, I've tried not to use any meth, heroin, oxycodone. These are the things that we're seeing, and we have to try to coax them into, one, how do we help you manage the pregnancy? 2, how do we help you manage the other problem? But it's not always somebody else is making me or telling me or whatever. Many times for us, it's the patient is thinking they're doing the right thing for their baby, and this is what gets them in trouble.
Okay. So this question relates to those we just talked about. And I think, Dr. Bartek, you stated that there's a fetal assault law, but it sounds like pregnant people are not generally charged with a crime if they don't change their medical treatment or medicine that's likely to cause damage to a fetus. That's what I thought. Moving to the next question. What is a fetal anomaly? Can women and girls get a legal abortion when there's one or more fetal anomalies?
So a fetal anomaly, just in general, is any kind of aberration from normal anatomy, normal organ formation, many of which are not considered lethal anomalies, meaning maybe not perfectly, but certainly compatible with life outside of the uterus. And so that discussion is very nuanced from the perspective, again, of always keeping in mind what the patient wants. A baby could be diagnosed with, having an absence of the kidneys. That's not compatible with life outside the uterus. The baby will pass away. It's almost a guarantee within typically 8 to 10 hours, perhaps after delivery. So if you have that patient who has this lethal anomaly, does she have the option in the state of Tennessee for a, sort of medical termination of pregnancy? So just at the outset, the diagnosis of absent kidneys isn't going to happen until probably 20 weeks anyway. So we're already in the latter half of a pregnancy. Again, the circumstances for how you logistically do that termination are completely different than your 8-week, I'm pregnant and don't want to be kind of situation. Again, and you have to also keep in mind, was this a desired pregnancy? What are the patient's beliefs, and how does she want to proceed? I've had more than one of these patients in my career. Most of these patients opt to continue the pregnancy, and whenever the pregnancy passes on its own in utero, maybe 32 weeks or so, now you have a situation where the pregnancy is no longer viable. The management, it is what it is, and it's, I won't go into the details of it, but it's no longer an abortion because the baby passed on its own, and that's what the patient wanted. I've had some patients who maybe they go into preterm labor, so they're still delivering early. It's still a non-viable pregnancy. The delivery goes the way it would go if it was a completely viable pregnancy at 32 weeks. It's just that the baby passes, within a few hours of life or of delivery, basically. So the situation would be, can that patient who maybe still has a viable pregnancy but wants a medical termination of pregnancy, there's a kind of a big emotional aspect that I think a lot of people don't think about. When you're in the grocery store and you have a 32-week belly, people come up to you and say, oh, how wonderful, you're expecting. The patient knows she has a pregnancy that's not viable, and that can have an impact on her emotionally that could be completely different if the patient had a pregnancy that was healthy and sort of quote unquote normal. So there's an aspect to that emotional side of things that people probably don't think about a lot. Can this be done in the state of Tennessee? To my knowledge, I don't think that it could be. It's not a situation where the life of the mother is in jeopardy, that type of a thing. So that patient might be faced with a situation of, I just have to let the pregnancy continue as it is with delivery whenever it happens with a viable baby versus, maybe the baby passes even beforehand. Even when I, for example, was in training and I trained in a state where this type of termination was allowable, it was not straightforward because a 32-week sort of planned termination, it's a delivery. It's not surgical. You induce the patient into labor and she has the baby the same way a full-term baby would be delivered. But that's going to take a while. It's going to take probably 24, 48 hours, maybe even longer. And where I train, for example, it's not just the physician team taking care of the patient, it's the nursing team as well. And if you have, staff who have their own beliefs about not doing that type of thing, you can't do it. You have to have staff who are available to help take care of the patient. The physicians, nurses are essential. We can't do what we do without nursing staff. So the physician can't be the only person to manage that situation for the entire course of the process. So it's a very complicated answer. The simple level of that, whether or not it's legal or can be done in the state of Tennessee, I think my answer would be no. I think that's, so again, the basic question of how does the Tennessee law affect how we can effectively manage our patients, that's a place where, yes, that's a clear limitation.
One of the things that I think is really worth emphasizing in these sorts of situations is how much the patient is suffering. Mm-hmm. When a mother is carrying a baby that far along, she typically expects to have this sweet, healthy baby at the end of her pregnancy, and then she gets this kind of news. And there are various ways of handling it, carrying the baby till it delivers and it dies, or have an abortion. But either way, this mother is really suffering, and I don't want to underestimate how severe that suffering is for her. It's full-blown grief for a child. And my own personal feeling is anything we do to make it more difficult for the patient to grieve and move on, I think that's really problematic.
Getting to what you're talking about, Dr. Bartek, I went ahead and skipped forward to another question around that. But before we move to that, we are 6 minutes from our end time, and I am going to ask if you all are willing to hang tight for maybe 5 to 7 more, because there are a couple of good questions that I do want to get in before we end. And so I commit to you that we will finish by 7:07. And our panelists are going to do the very best that they can to answer the questions quickly, concisely, and fully. That's no hard feat, right? But as we talk about the suffering that parents, mothers, fathers have as a result of knowing they can't get an abortion, get abortion care, and that patient is already suffering with all of these things, what is done or can be done? And then my own personal question that I didn't write on a card is, are there then services that by law they can access if we are putting in place things that don't allow them to access the care that they need? So thinking about the mental health care, I know the answer to the question. Because I didn't even ask it concisely. So do the very best that you can. I have committed to 7:07. And so as we think about the mental health of the patient, what happens after they leave the hospital? What kinds of opportunities and options are there for them?
First of all, the obstetrician can consult psychiatry if that's indicated, if they're in the hospital. That's one way of getting them quickly into the system. Unfortunately, psychiatric care is not as robust as it might be in Tennessee, and sometimes access is limited. But there are various mental health clinics for people who are on TennCare or on Medicare. There are private physicians and therapists and so forth that one can refer the patient to for help. I mean, basically what we're often dealing with is grief, fear, anger, all kinds of intense feelings that are stirred up by this experience with them, with the pregnancy and abortion.
I think just to kind of generalize it, I think a lot of the controversy around, pregnancy terminations, there's so much in the media that gets put out there that's just very crass, and it just makes all pregnancy terminations this crass, last-minute decision where it's just people who maybe made a poor choice and now they have an unintended pregnancy, and let's just help them terminate that. There's a lot of that that's put out there in the media. But so much of this, the patient description that I just described, that patient has been taken care of for months and months. And it's been an interdisciplinary medical team between the obstetrician, the high-risk obstetricians who made the diagnosis, the nursing team at the hospital, the NICU team at the hospital, all come together and make a plan so that that patient's experience can be as well supported as it can be. And so some of that grief management actually starts with programs in the hospital. Just kind of as an example, a pregnancy such as this, that patient typically will have a dove on their door. And so it's a sign for everybody who goes past that door that the patient in this room is experiencing something, unlike what everybody else on this floor is experiencing. So there's a lot of support that starts in the hospital itself, leading up to the delivery and then through the delivery. And then on the other side of that, as follow-up in the office, there's always a discussion about kind of grief, management. A lot of patients, find support in their churches. And if whatever the patient has, whatever they're comfortable with, if they need a referral for counseling, a referral for psychiatry, those are things that, I'm certainly not the counselor. I can't provide that kind of support specifically, but I can help to arrange it for the patient. So a lot of it comes, it's not these crass last-minute decisions. It's something that is, just supported through the many, many months during the process of diagnosis, during the process of delivery, and then through the process of recovery for all of that. And then also the other thing that I can help with is, looking ahead. Like, you had this horrible experience and, maybe some of your options were limited, again, to put it back to the state legal level, but this is how we can, hopefully move forward from this experience and look towards the next thing, maybe another pregnancy, et cetera.
Thank you. I'm going to go back because these next two questions relate to travel. Is there an organization that can help with travel funds to receive abortion health care outside of the state that anyone knows of? And can a doctor, if they know of that, provide that information and not be outside the law? You don't want to know.
I was going to say, I'm not going to provide legal advice to the physicians here this evening. They will consult their own lawyers. But my guess is that that's probably not a call that they would necessarily want to make. But yes, for members of the public, that includes the physicians, but maybe not in your practicing capacity. For members of the public, yes, Abortion Care Tennessee, ACT, is an organization that provides funding and assistance to help people travel out of state, and Mountain Access Brigade as well is another abortion fund in Tennessee. They are both they are solid organizations, and they provide discreet, robust care for folks who are trying to get out of state.
Similar to that question, if you travel out of the state for abortion health care, can you get in trouble when you return? Is there any record of your abortion in other states that could be accessed later and used against you that anyone knows of?
I assume that there will be a record, that there are record retention requirements for physicians, and that records will exist in other states if care is accessed out of state. Does that follow you back? That goes back to my previous point that the trigger ban here in Tennessee specifically says that a woman cannot be prosecuted for obtaining or attempting to obtain an abortion.
Thank you.
The only thing I would add to that would be whatever record that is, that's a medical record, which is protected by HIPAA law. So unless there was some actual legal, prosecution pending, there's no way that people who don't need to know that would ever need to know that. As a provider, if a patient had a surgery, I need to know that my patient had a surgery. So that's within the confines of the, doctor-patient relationship in the exam room, where we don't need our senators like we were talking about before. So it's medical information. The doctor should know the information, and it's just about taking care of the patient properly for future, medical care.
For years in the emergency room, we take care of Planned Parenthood patients who have had a procedure and show up in the emergency room on the weekend, at night, when there is no one covering Planned Parenthood. This is no different. If there's a complication, if there is something that has not necessarily been, I don't like to call it all complications, something that it's always possible that this could happen after this kind of procedure and you show up in the emergency room. We treat the patient. Again, it gets back to EMTALA, and EMTALA says if you have a medical condition and it is life-threatening or potentially life-threatening, then you get care. Showing up from out of state after having a procedure is no different than the guy who was in Florida who had his heart attack and had a bypass, and they kept him 2 weeks, and he came home and he comes back and he has a mediastinitis or a wound in his sternum that has to have it opened so that he can't close his chest. It's no different. It's still medical care rendered. This just happens to be an OB patient who had a procedure out of state and is here in the ER and needs our care.
That's good to know. Final question. We have 4 minutes, so each of you, I'm going to ask you to answer this question and attempt to do so in 30 seconds or less, because I'm going to invite the PRH team to come up and give us what potential next steps might be, how we can connect with PRH, how we can connect with you all to further this work, further what's next, et cetera. So the final question, what can we do to make a difference in anti-abortion laws? How do we move the needle? 30 seconds.
I think that you're doing it right now by being interested and engaged in this issue and learning what's actually happening from professionals who are seeing it in their practices. And, people out there have stories to share, and some of those stories are starting to be told to legislators and lawmakers and policymakers. And I think it's important to hear those stories and for us to continue to talk to our lawmakers even when we don't agree with them. We have to have those difficult conversations, and you, maybe in Sumner County, if you want to see a change in the law, maybe that's difficult for you all to access your lawmakers and get through to them. But I encourage you and stand with you and hope that you'll keep doing that.
I don't have a lot to add to that other than I think just taking measures to help educate ourselves about some of the nuances of, terminations of pregnancy and what they actually mean. And again, taking away that sort of crass, uncaring nature of abortion care, and understanding that there is truly a medical component to that. There's a lot of psychology behind it, like we've talked about. And to kind of add to abortion care, well, if abortion is such an issue, and the biggest issue is people who have unintended pregnancies and, they want to have options, how can we also kind of on the other side of it help to educate patients or people on how to prevent those unintended pregnancies and how to, have contraceptive access and that type of a thing. So I think I don't have a great answer to the question on how to push the needle, but to add those extra components to the whole process, I think, is important.
I also think, there's a whole new generation. I'm old. There are a lot of, and I don't need an abortion, but there are many, many young people coming along who may. or who may have complicated pregnancies that bring up some of the issues we've discussed today, to the degree that we can encourage these people to make their voices heard and to vote, because we've had relatively low turnout of young people, and yet these are the people that are most impacted by some of these issues around abortion access. So to vote, to educate young people, encouraging them, and really convincing them that they can make a difference for their future reproductive care, for the future of their children.
I think that everybody on the panel has already said the components of what needs to happen, and I would add that you just need to get involved and get educated. Read it for yourself. Someone said, you know, the news is there to give you the worst side of it. It's there. Yeah, they have bright spots that say, oh, today, and then they get right back into the weeds of how bad things are. If you're relying on the news simply for the abortion stuff, oh, it's shock and awe. It's all shock and awe. And I'm not saying the laws aren't bad. I think they're horrible, to be perfectly honest. But the bottom line is you need to know the law. One of the late night hosts did something. He went out on the street and just asked people about the First, Second, Third, Fourth Amendments. How many amendments are there? What is the Constitution? And it was just horrendous, the answers that we were getting from. And I said, you know, I remember having to read the Constitution. I can access it when I need it. But I do know that some of the things that I'm hearing from people's mouths, that's not the Constitution. We the people. Nobody could finish it, and here we go. So for me, I think this is just the same thing. Turn off the news, and if you have questions about what you heard, read the laws yourself and help people under you read the laws and just encourage the intelligence of the people who are affected. And then, like everybody has said, get involved.
Awesome. Thank you. So, Dr. Dwayne Harrison, Dr. Nicole Oliver, Dr. Ann Bartek, and Tyler Chance Yarbrough, thank you very much for your considered and thoughtful engagement in this conversation. I am so glad to have met you tonight. A lot of my personal questions have been answered, and my interest has been piqued. And so we thank you. If we can give them a hand. We also thank you, audience, for coming out and being with us tonight. Those who are watching on YouTube and those who are in the building, we really appreciate it. And so I'd like to invite Sandy Gaskins up amidst all of my stuff to dismiss us.
Again, thank you all for being here. For anybody who's interested in learning more about our organization, simply send us an email at prhtenen@gmail.com. I'm going to be posting that on the YouTube channel as well. And I will get you on our emailing list. Right now, we are meeting every month in Sumner County at St. Timothy Lutheran Church. Those are posted. Again, they'll be posted on our social media sites, Instagram as well as YouTube. And thank you, panelists, one more time. I know it's you guys are busy and have a lot to do, and we really appreciate you being here for this. Thank you.